Good afternoon, everybody. It's a pleasure and privilege to be able to present this instruction course on incorporating the latest glaucoma surgical devices, conundrums for the Indian glaucoma surgeon. So we'll directly come to what are the topics that we'll cover. So, what are the new surgical techniques? Then GAT and its innovations, learning intraoperative gonioscopy, stents and other devices which are currently available in India, new vistas in pediatric glaucoma surgery, and what are the options when we have a failed trabeculectomy. So we have with us Dr. Anil Kumar Mandal. He needs no introduction. He's a glaucoma specialist with LV Prasad Eye Institute, formerly trained in Nilratan Sarkar Medical College and All Indian Institute of Medical Sciences, and a visiting research fellow at Kellogg Eye Center. And he's a recipient of Shanti Saurabh Bhatnagar Award in the year 2003. Then we have the young and dynamic Dr. Siddharth Dikshit. He did his post-graduation in CMC Vellore and subsequent glaucoma fellowship in LV Prasad Eye Institute. And his main areas of interest are stem cells in glaucoma, angle closure glaucoma, pediatric glaucoma, and secondary glaucoma. And he has a special interest in innovating modifications in glaucoma surgery. I'm also a fellow of LV Prasad Eye Institute and currently practicing in Center for Sight, Kolkata. So we'll begin with what are the new surgical techniques that the Indian glaucoma surgeon at this point of time has. So for some time, those of us who practice glaucoma in India were confined to only the following surgeries, either the trabs or the tubes. So either you do a trabeculectomy or do a phacotrabeculectomy or SICS trabeculectomy, or you do the tubes like the Ahmed valve and the Adi valve, or if you are interested in pediatric glaucoma surgery, you can do a trab with trab. So this is all the armamentarium that we had so far. But in the last 15 years, there has been a lot of innovations in the glaucoma sphere. And in the tube scenario, we have the Ahmed Clear Path that is currently launched in India. That is modification of the Ahmed valve, in that it's a valveless implant, but it does not require the dissection of the muscles as the Adi does. And the maximum number of innovations are in the minimal invasive glaucoma surgery sphere. And we have several of these which are available in India and practiced in various centers. So basically the purpose of today's instruction course is what are these new techniques that are available, and how can we update ourselves and make us competent in these techniques. So the trabectome is practiced in some centers. The endocyclophotocoagulation is also available. GAT is becoming very popular in LV Prasad and in some other centers in India. The bang is another technique which is a low cost technique. The eye stent or the eye stent inject again are practiced in quite large numbers in recent times. The KDB is also available, and the Zen gel stent, it's not currently available, but maybe it is going to come in a short time. So the Ahmed Clear Path is a new innovation in glaucoma that has sort of revolutionized the scene, because we know that the long-term results of Bardwell implant are somewhat better than Ahmed valve in terms of IOP control. And the problem with the modification of the Bardwell implant as the Adi valve is that it's a bulky implant, and it requires a dissection of the rectus muscles, and many glaucoma surgeons are not comfortable with that, and it also takes a large amount of time. So this is a new modification of the Ahmed valve. It's a valveless implant, and it has two sizes, and the smaller sizes, it can actually be done without dissection of the recti muscles. So this is known as the Ahmed Clear Path. It's a valveless drainage device. It's made of a flexible material and it's designed to conform to the shape of the eye. It's available in a 250 millimeter square and a 350 millimeter square sizes, and it comes with a pre-packed 223 gauge needle and a 40 polypropylene ripcord, which is optional. You can use it. So the benefit is that it is easier for access for implantation with anteriorly placed suture points. As a modification of the design, and this 250 size is a true single quadrant device. So you get the advantage of a valveless implant without having to dissect the recti muscles. That is the advantage of this. Next, we come to the various minimal invasive glaucoma surgery devices, and these devices target either the aqueous humor inflow, or they target the trabecular meshwork, or they target the subconjunctival space or the suprachoroidal space. So the techniques which target the inflow, we already had the transscleral cyclophotocoagulation we used to do, but now there are some modifications, like we have the endoscopic cyclophotocoagulation and we have the micropulse diode. So these are modifications of the which target the inflow system. Now the maximum number of innovations are in this segment, which target the trabecular meshwork Schlem's canal. We know the juxtaclavicular trabecular meshwork is the site of maximum resistance, and here again you have two types of devices. One is the devices without stenting, and other are the devices which are sort of stents. So without staining, we have the gonioscopy assisted transluminal trabeculotomy. Dr. Siddharth is going to discuss elaborately on that. So you can do either with a vicryl suture, with a proline suture, or you can use this illuminated microcatheter, which Dr. Mandal is going to discuss. Then you have the viscodilatation of the omni, but it's not available in India. Then we have a procedure which is the bent angle needle goniotomy, or bent ab interno needle goniotomy. So which is a low cost technique. It's just bending a simple 26 gauge needle that will help you to do this technique. Then we have the trabectome, which requires a specific instrument, and then a Cahook dual blade, which we'll discuss. And then with stenting, the most popular are the eye stents. They have a long history. They have been used for more than 10 years now worldwide, and they have been recently launched in India. So we have the original eye stent, and then we have a modification of this eye stent which is called the eye stent inject. These two are available in India. Then there is another thing called the eye stent inject W, and another thing they're working on is the eye stent infinite. Then we have another device which is called the Hydrus. It is again a flexible aqueous drainage device, and it also acts as an intracanalicular scaffold. It's a longish device. It's not available in India currently, but it's quite popular in European countries. And then we have the bleb forming procedures also. The MIGS are the traditionally they have a few characteristics, like they are performed ab interno. They are easy to perform. Most of these are very safe, and but there are certain modifications of these devices. They actually they form a sort of bleb, but the bleb that we see in trabeculectomy, it's different. And here we have two devices. One is called the Zen gel implant, which is which is an implant which is a 6 millimeter porcine gel stent, and it is implanted ab interno by endoscopic assistance. However, it can be also done ab externo, and mitomycin C may be used. This is not currently available in India, but Allergan is working on it, and maybe in a few months' time we will see it in the Indian market also. Then there is another device which is called the pressure flow microstunt. This is done ab externo with limited conjunctival dissection. This also has shown good results, but it's not currently available in India. So this is the first part of this presentation, which is what are the currently available devices. I have two more talks. I think I will continue them, and then I will let Dr. Mandal and Dr. Siddharth do the video presentations later on. So whatever these devices are, as we have seen, the learning intraoperative gonioscopy is critical if you are keen to do this MIGS procedures. And here a few points need to be kept in mind, like the position of the surgeon is somewhat different from the position we are routinely accustomed to while doing phaco. So while doing phaco, the working distance is much less, but in this sort of procedures, this is MIGS procedures, the microscope has to be tilted towards the surgeon. The eyepiece has to be tilted towards the surgeon, and the patient's head has to be tilted away from the surgeon. So this makes a long working distance, and this may sometimes require some adjustment in the initial phases. So here are a few tips. Avoid using the foot pedal to refocus on the ocular surface and subsequently in the angle and the gonioscopic view. Instead, we can manually lower the microscope each time to bring the target tissue into view. So there we will be able to keep the focus intact. So the microscope tilt is very important, because what we want is we want to view the unfaced view of the angle, and for this we have to tilt the microscope about 35 degrees towards the surgeon. So we can measure this with the help of an app which is called the Compass app, that's available in the iPhone. So it's very easy. You can put the iPhone there and you can gradually tilt the rotating part of the microscope, and when it comes to 35 degree you can put a mark, so that subsequently you can always adjust the microscope position easily. So these are the differences that a typical cataract surgeon has while he tries to do some any sort of MIGS surgery which requires intraoperative gonioscopy. Like there is a position of the elbows, the position of the hands, the red reflex is not there, and the tilt of the microscope and the tilt of the patient's head has to be there. So there are special gonio lenses to see this, to view this angle. The Swan-Jacob gonio lens is what we are most familiar with, but then there are lenses which come with the eye stent. These are called the SX and the S lenses, the gonio prism. So they give a very good view of the angle. Then there are a few more modifications like the TVG lens and the ocular hind lens and the eye prism clip lens, but the Swan-Jacob lens and the lens that comes with the eye stents, they're pretty good. So when we are operating on the right eye, we usually sit temporal for these surgeries so that we target the nasal angle. So when we are operating on the right eye, the side of the palm that rests on the forehead, and it will act as a pivot, and we have to hold the lens very gently so that we do not distort the view. When we are operating on the left eye, the side of the palm that rests on the zygoma. So this is in short what we have to do. The microscope has to be tilted towards the surgeon about 35 degrees. The patient head has to be tilted away from the surgeon about 35 degrees. And we have to maintain scope sterility while adjusting oculars, and we have to make the seat or the table adjustments. So this is a short video of the intraoperative gonioscopy. And how to put the gonioscope in place. The video is self-explanatory. So the eye stent is inserted inside the trabecular meshwork, and the fluid flows into the Schlemm's canal and then via the collector channels. The anterior chamber has to be filled with a cohesive viscoelastic like Hilon. And over the cornea you put viscoelastic. So there you see the position of the microscope. So the assistant is rotating the movable arm of the microscope. This is quite different from the normal position of the microscope which we are used to while doing phaco. And you can see a mark is being made. So the tilt is around 35 degrees.
And macro, you need to show the
Now the patient has to be, the patient's head has to be rotated, and make sure the patient is comfortable while we are doing this maneuver. So because you are operating under very high magnification, the comfort factor is very important. So viscoelastic is put, and this is the eye prism S that gives a wide field of view and a very good clarity of view. And now you can see the angle structures, the pigmented trabecular meshwork, the scleral spar you can see. So we have to avoid very light, avoid putting more pressure, because this will put a lot of stress on the cornea and it will distort the view. And then we proceed with whatever MIGS procedure we are trying. Now we must ensure that our assistants understand how to turn the operating microscope and the patient's head to obtain the best view, and we may use a pillow under the patient's shoulder to help improve the visualization. We may use pilocarpine so that we get a better view of the angle, and we have to put viscoelastic inside the eye and over the cornea. So this is the view that we get: the Sholby line, the pigmented trabecular meshwork, the scleral spur, and the ciliary body band. So I'm indebted to Mr. Soikat Datta from Glaucos for sharing this video. Now, there are a few techniques which help us to identify the trabecular meshwork. If the trabecular meshwork is very well pigmented, it's easy, but if it is not, then we can slightly lower the intraocular pressure, and that will cause some blood reflux into the Schlem's canal. And some authors have also suggested that trypan blue staining can be done to visualize the trabecular meshwork. So what are the keys to successful intraoperative gonioscopy? We have to practice intraoperative gonioscopy on a select number of patients that are having standard cataract surgery at the end of the case. So while we do a routine phaco, at the completion of the surgery, we can gently turn the patient's head and turn the microscope, and we can, through the sight port that we have already done for the phaco, we can introduce a Sinski hook or a dialer, and we can touch the trabecular meshwork, and we can get a tactile feedback about what the trabecular meshwork feels like. So once we have done a number of these demo procedures, we can then actually take up the case. So it is said that if you never try, you'll never know. So I will continue with the third part before I move on to Dr. Mandal and Dr. Siddharth's talk. So out of these devices, we have seen there are a lot of MIGS devices currently available worldwide. So in India, only a few are available. And what are these and how to go about this? So the inflow is managed by the endocyclophotocoagulation, and then we have the eye stent and the eye stent inject. Then we have the trabectome, the Cahook dual blade, the GAT, and the BANG. These are the currently available devices in India. And as you can see from this slide, the worldwide market of MIGS techniques and devices is increasing. So this is a projected value from 2022 to 2029. You see all the countries, Japan, South Korea, India, China, and rest of Asia Pacific, having a phenomenal increase in the number of these MIGS procedures. So in the next few years, I think a lot of modifications of these devices and many more devices can come up. So we have to update ourselves regarding these techniques. So where basically MIGS lies in the spectrum of glaucoma care? So as you know, a patient with glaucoma can present us with mild disease, with moderate disease, or with very severe disease. So mild disease we can take care of by glaucoma medications or selective laser trabeculoplasty, and for very severe disease we have to resort to our age-old trabeculectomy or tube shunt surgery. But in between there will be patients who have mild to moderate glaucoma, where you can manage these patients with these MIGS techniques. Why? Because their safety factor is much more compared to trabs and the tubes, and they are minimally invasive. At the same time, many of them have shown good IOP control. So they produce more stable IOP without medications or less medications. So the compliance issues and adherence issues are not there, and they give overall a better quality of life. So for mild to moderate disease, we can aim for the strategies that target the trabecular meshwork, like say the eye stent. And for progressive disease, we can target the strategies that direct the suprachoroidal space. And then for refractory disease, we can have the strategies that target the subconjunctival space. So it is a balance. Glaucoma surgery is always a balance between safety and efficacy. These MIGS procedures may be slightly less efficacious in terms of IOP control compared to trabs or tubes, but they do reduce the medicine, the number of medicines used, and they are devoid of the dangerous side effects of glaucoma surgeries like hypotony, maculopathy, high FEMA, bleb-related complications, etc. So out of these, the eye stent is the one that has been most published worldwide. The eye stent, it comes in the original in various variants. The original variant is known as the eye stent. Then came the eye stent inject, and then came the eye stent inject W. So the eye stent and these MIGS procedures, who are the ideal candidates for these procedures? These are patients who have mild to moderate glaucoma, and they patients who have difficulty taking medications, patients who have side effects or poor compliance with these medications. And these patients must have open angles, because all of these devices are described in open angle glaucomas. So to the left of the picture, we have the original eye stent. This is a L-shaped, very miniature device. This was the smallest device that is implanted in the human body before the eye stent inject came. So this is made of titanium, and it is heparin coated, and it is injected, it is implanted into the trabecular meshwork, and it will shunt aqueous from the trabecular meshwork across the Schlemm's canal into the collector channels. And researchers found that if we put one more eye stent, the response is better. So they came up with the idea of this eye stent inject, where two eye stents are implanted into the trabeculum, into the Schlemm's canal, a few clock hours apart. So this is a short video of the eye stent and the eye stent inject. So again, you see a gonioscope, an intraoperative gonioscope is used, and we get a clear view of the angle. This is the original eye stent. This is a L-shaped implant. So at an angle, the surgeon pierces the trabecular meshwork into the Schlemm's canal and then injects the implant. And you can see there is the inlet that's visible. So the problems of this technique may be the exact location and the exact positioning of the implant may be a little difficult, but with practice one gets used to it. And then this is the eye stent inject, where two devices are implanted. So in the original eye stent, it has to be angled somewhat, but here it is a straight implantation directly into the trabecular meshwork. So you can see one implantation being done, and a little bit of bleeding is common. It actually indicates that the stent is placed in the proper position, and then a few clock hours apart, you put another eye stent. So then we have the trabectome. The trabectome, again, it requires a machine, and that has a foot plate, and it sort of excises or coagulates the trabecular meshwork with this electrocautery. This is a short surgical clipping of the trabectome, an animation. So again, whatever technique you're using, you have to master the technique of intraoperative gonioscopy. So here the gonioscope is put in place, and then this is a tip of the trabectome that is being positioned. And as the surgeon presses the foot pedal, a strip of the trabecular meshwork is excised. This is done on the other side, and there is continuous irrigation which removes the blood and the debris from the antechamber. Then there is a Kahook dual blade. It is a single-use blade with very sharp tips and sharp edges, and it is said that the advantage is that the sharpness of this instrument, it leaves less tags from the remnant of the trabecular meshwork. So this is a short video of the Kahook dual blade. How is it done? It's an animation. So it has a very sharp tip and sharp edges, and the latest modification is known as the KDB glide. So clear corneal incision is made, and We reform the anterior chamber with viscoelastic, put a gonio lens, and with a sliding motion you have to remove the strip of the trabecular meshwork. So because the edges and the tip is very sharp, the remnant tags of the trabecular meshwork are much less, and it is said that the chance of fibrosis is less because there are less trabecular tags. Then we have a modification called bang. So this or bent ab interno needle goniotomy or bent angle needle goniotomy, which just requires a bent needle, no expensive instrumentation, that can also be tried. And then we have the gonioscopy assisted transluminal trabeculotomy. So here with a suture or with an illuminated microcatheter, you can circumnavigate the entire 360 degree of the Schlemm's canal. I'm not going to discuss this because Dr. Siddharth is going to elaborate on this. So with that, I come to the presentation of my talks, and the next speaker will be Dr. Siddharth. So he will be presenting, one is on the GAT and its modifications, and another will be the options that we have once a trabeculectomy fails. And then we have Dr. Mandal, who is going to speak on his on a technique that he has innovated and that is being widely appreciated in the management of primary congenital glaucoma. So over to you, Dr. Siddharth.
Thank you, Dr. Debashish, for the kind introduction and the invitation, and making me a part of an instruction course where you and Dr. Mandal are co-instructors. A privilege and a pleasure. So, 2 years back, when the pandemic struck, we were looking for options other than trabeculectomies, because the way to do a safer trabeculectomy is to have releasables in place. Can we switch off this AC? It doesn't feel good when it comes from behind directly onto you. ये AC या तो उधर कर दीजिए या बंद कर दीजिए. And this needs management, including releasing the releasables, bleb massage, which was not happening during the pandemic. So it was a time when you had to find a solution which doesn't require too much of a management and could do with a few visits alone. And that is the time when during a webinar, webinars were everywhere, from Europe, from the US. During one such webinar, we saw what GAT was. GAT had become the primary choice procedure for most specialists in the US, and that is what got us interested, and we started doing it gradually and mostly learning on our own and based on videos that we saw on the internet. The purpose of today's talk that I will give is to introduce you to GAT to such an extent that you yourself should be capable to start trying GAT, and when you see videos, you start seeing more than what a novice would see. So as I will skip the slides that Dr. Debashish already has discussed. So this was developed by Dr. Davinder Grover, and he now has the maximum number of GAT cases and the longest follow-ups. He recently published an excellent series of follow-up of or more than 2 years with success rate more than 90%. This diagram is very important to see because this means that most of the collector channels are located in the inferonasal aspect of the Schlemm's canal. So if you do a hemi-GAT, this is the area that you should be targeting. Now, when you do something like bent angle needle goniectomy or eye stent, this area doesn't get targeted. And you leave a lot of area which is potential area of drainage, and that is why you see that the efficacy in lowering intraocular pressure of eye stent is lower than that of bang, which is lower than that of GAT, and so forth. For performing GAT, the classical indication was only open angle glaucomas, but now with experience we also do it for closed angles when you have access to nasal angles, which basically means there should be no significant synechiae, and a small synechiae doesn't matter, you can manage that. No history of trauma, traumatic glaucomas don't really do well, and mild to moderate glaucoma where the target IOP is not in low teens and the patient is able to use 1 or 2 AGMs economically and is not allergic to them. Patient on anticoagulation medications who can't stop it, patients with bleeding disorders, and grossly closed angles and history of ocular trauma are contraindications. Now, patients on anticoagulations who can stop it is not contraindications. Patients with closed angles where you can see the nasal angle is not a contraindication. Multiple advantages are there. Let us look at one full recording of a continuous GAT surgery. Okay, let's go through the requirement. You need a microscope with tilting capability, as we saw earlier. And these are the various options of gonioscopes. These don't come cheap. These are expensive, but now you have a disposable gonio lens called iPrism SX, not the S. S requires a right and left-handed this thing, so you need one for each eye. And SX is not only smaller, which allows you greater access to the cornea, it doesn't interfere with the instrument, but also you can leave it on the eye without holding it. So the disposable version costs less than 7,000. So if you maintain it well, you can use it for many, many months together, if not years. We typically use a Swan-Jacob lens. Some surgeons prefer the ocular hill lens or the Ahmed surgical gonio lens. The 3 lenses that you see here, they do not require you to tilt the microscope. They will give you the image of the angle with a straight microscope, but you look at the cost of these devices, it's quite prohibitive. You need an umbrella tipped 50 Prolene suture, cohesive viscoelastic, and be consistent with the viscoelastic that you use. If you change the viscoelastic, you will have different intraocular pressures when you leave 30% of each. Leaving 30% of HPMC is different. Leaving 30% of 2% chondroitin sulfate is different. So you will have difference between whether you use Orogel or Helon GV or Viscoat. So be consistent with the kind of viscoelastic that you use. And the most expensive thing is the Grishaber serrated forceps. Remember that you need a serrated forceps. You use a smooth forceps that will not push the suture inside. And you get titanium versions of it, which in the long term may actually be cheaper. I will also skip this slide. Now let us look at one surgery here to understand what the steps of the surgery are. So a paracentesis needs to be made in order to access the nasal angle. Wherever is the site of goniotomy, initial suture entry, the paracentesis should be 90 degrees away from that. And the site for entry for the MVR or 26 gauge needle should be bang opposite to it. So if I am intending to make a goniotomy at 3 o'clock, then the incision for the suture is at 6 o'clock. This is the right eye. And because this is a phakic patient, I am inducing meiosis with pilocarpine. I don't want anything to go and touch the lens. So you can do it in phakic patients also. It doesn't always need to be pseudophakic. Pilocarpine should always be injected under air bubble because the sphincter muscles lie under the pupil. So if you have an air bubble, the pilocarpine will go directly to the targeted area. It will otherwise also go, but you will have greater concentration. And then I always use Orogel because that is what I'm used to. You can get used to different viscoelastic also. And I use a dispersive viscoelastic on the cornea, which I find to be more clearer and spreads much easier. The only challenge is the air bubble that you get with these patients, these things. This is an umbrella tip suture that we prepare ourselves, and everything, including the suture and the forceps, should ideally be placed inside the eye before you place the gonio lens. Every second that you place the gonio lens on the eye, you are losing viscoelastic, and you don't want to miss on that. Here I wanted to visualize the angle. If you see here, you get a very, very good view of the angle. The cornea is clear, the lens is clean, and this is called the en-face view of the angle. Okay, and you go and incise with an MVR the top edge of the trabecular meshwork to get a cleft. You can just push it down a little bit to see that you are confirmed that you are in the right plane. Now go and hold, say, a half to 1 clock hour away with just the tip, and inject or push the suture tip both backwards towards the Schlemm's canal wall and inside. So every time you push this inside, you have to go towards the Schlemm canal and then inside, towards the Schlemm's canal and then inside. So with this movement, you will be able to push in more and more at one time, and within 12 to 15 strokes, your GAT will be done. At this point of time, you are likely to see some ooze or bleed from the Schlemm's canal, which is a good sign. Why is it a good sign? It means that the Schlemm's canal is in continuation with a vascular aqueous vein or collector channel, which means there is a patent pathway of the aqueous to go into this collector vein, collector channel and the aqueous veins. You see the eye keeps moving a little bit, and that is because you should be facing some amount of resistance when the suture is in Schlemm's canal. If you face no resistance or the suture does not move, especially if you feel no resistance, it typically means that it's gone into the wrong plane. It's in the sulcus or in the suprachoroidal space. So after 10 to 15 strokes, 12 to 15 strokes, you should be able to see the other side of the whenever the AC shallows. Now look, what is the amount of viscoelastic that you need to inject? Okay, I'll come to that later. So you grasp the other end with the forceps, pull it over the other end of the suture, and use a McPherson's to just pull both the ends to achieve a 360-degree opening. And in this situation, you want to leave a frill of viscoelastic all around. I used to be very scared as a glaucoma surgeon who doesn't like viscoelastic in the eye. I used to be very scared leaving viscoelastic. But believe me, around the size of the rexis, so around 6 millimeter centrally, you should aspirate all the viscoelastic. And that is why I am going with a vertical IA, so that it don't disturb the viscoelastic on the sides. So I want to leave all the viscoelastic that is beyond 6 millimeters of the central anterior chamber, and this gives you a very, very good control over the bleed without raising the intraocular pressure. And if you see, this whole surgery is over in less than 6 minutes here. So once you get used to the surgery, this is a very, very simple surgery to do. And post-operatively, the regimen will depend on what kind of surgery have you done and whether it is angle closure or open angle glaucoma. What is common in all the three is Nepafenac, 0.1%, 3 times daily for 6 weeks. Prednisolone acetate is something that I don't give now. I give them something called Miticom or Vigadexa, which is a combination of dexamethasone and moxifloxacin for 2 weeks, for 10 days, and stop it. You don't need any steroid more than that for phacos or phacogats or GATs. And in patients with open angle glaucoma, I give homatropin, or if in angle closure, the angle opens up wide and clear, I give hometropin. Otherwise, in a patient where I have done only GAT in phakic and in angle closure, I give pilocarpine 4 times a day for 4 weeks. So pilocarpine is required when the angle is narrow and the eye is still phakic. So prednisolone is something that you should remember that I have stopped using, and since then the steroid responses have become very, very low. So Dr. Devashish has already mentioned, I'll just repeat a few things. There are certain steps that you need to take when you're initiating your mixed procedure or Schlem's canal procedures. Get used to the posture. Okay. I remember when I started doing SICS and I was making the superior incision. Please remember that we don't in our life do anything else apart from ophthalmic surgery like this. Every time our hand comes in this manner, right? So doing this, my wrist would pain so much, and all of us would have taken some time to get used to that maneuver, because there is nothing else that we need to do in that way. Similarly, when you do GAT, the entire chemistry or physics of movements, the distances, the posture in which you need to make those fine movements changes. So you need to get used to that posture. It's like lifting one leg up and punching continuously. It doesn't happen easily. Your leg will keep moving when you punch. So in order to keep your leg still and punch repeatedly, you need to practice it. Similarly, when you are in this posture, you need to practice not only being able to focus, but also being able to move your hands. So in these patients, in patients where you do cataract surgery, first get a good view. And the key to get a good view is to go into a really high magnification. Because if you can see something really well in high magnification, it means that you're in perfect focus. And that is the most crucial differentiator between ability to do or not to do a Schlem's canal based surgery. So this is the most important step. Then when you do a cataract surgery, the next thing that you should do is take a Sinskey hook or an iris repositor and go and touch the Schlem's canal. Go move the hand along the Schlem's canal a little bit without depressing it. That will give you practice of the movement that you need to do before you start doing that. And once you are comfortable with it, please do not hesitate in doing a GAT. You can contact anyone. I think a lot of surgeons across the country are very approachable. And once you start doing it, you may have some industry support also who can help you start the Schlem's canal based surgery. I will tell you, it was a difficult journey for me. I am not an excellent natural surgeon like Dr. Mandal. It was a difficult journey for me. But today, as you see, the surgery doesn't take much time in more than 95% of the cases. So it's worth the effort. Don't give up. Just got to do it. Thank you. I will very briefly give an overview of how to pick up a surgery once your trabeculectomy has failed. Now, trabeculectomy is, and for many, many years to come, will remain the choice of surgery when you deal with any advanced glaucoma or a situation where you have a lower target IOP, but it also fails. So, the first step is to decide whether it is a failing trabeculectomy or a failed trabeculectomy. A trabeculectomy where the pressure has started rising, you need a CPR for the bleb. You don't give up right away, right? So especially in the early phase, you don't give up right away. Starting intraocular medication, especially aqueous suppression, may be harmful for your trabeculectomy and may reduce the bleb height further when you have done a trabeculectomy, because the bleb height will reduce with aqueous suppression and you will repeatedly need more and more surgery medications after that. So this is basically your options when you have a failed or failing trabeculectomy. The trabeculectomy, when you see a failing trabeculectomy, you have to remember it can fail at 3 levels. One is at the level of the ostium, where something might be blocking the ostium. Do a gonio, make sure that the thing is blocking the ostium. If you see a fibrin or a clot blocking the ostium, just give steroids, it will resolve. If it doesn't resolve and fibrin becomes a fibrous layer, then you can use YAG laser along with a gonio lens, typically a 3-mirror gonio lens, and go and tackle with that membrane, aiming it at the ostium and especially at the edges of the ostium. If you open the edges of the ostium using Nd:YAG laser, you can open it. The second thing is the scleral flap. And the third thing is conjunctival fibrosis. Now, okay. So this is how a patent ostium looks on gonioscopy. And before doing anything else, like tackling the scleral flap or conjunctival fibrosis, you have to make sure that the ostium is patent. In patient who has a, okay, there's something wrong with the video here. So I always do my trabeculectomies with a releasable, and when there is a fibrosis, I just pull it out, and that gives you a backup or a second chance to your trabeculectomy for the first 4 to 6 weeks. Bleb massage, you yourself doing it or teaching the patient how to do it, and 5-FU injections are all methods of countering fibrosis, along with increase in steroids. You can do and should do a needling, especially in a patient with early failure. What's wrong? Okay, so this you see is a very, very shallow bleb. With a 26 gauge needle, I am going right. Something is not right. It's such a flop show when you are counting on the video and it doesn't play. So basically what you need to do in needling, you can do two things. One thing is to overcome the failure at the scleral flap level. In that kind of a situation, you need to just go to the scleral flap edge, go under it and clear it. If you see a significant amount of huge bleb forming, it means that the conjunctival fibrosis has not yet set in. But if you have lifted the scleral flap, moved the needle under the scleral flap, and you still don't see a huge bleb forming, it means there is a significant amount of conjunctival fibrosis also. There you will need to go cut the entire fibrosis, and that is when needling doesn't work. Needling is a procedure, the success of which varies from 6% to 92% in literature. And that is because you combine various kinds of needlings for various kinds of failures. So the success rate will be 0 if the ostium is blocked. Success rate will be very high if you just have scleral problem. Success rate will be in between these two if you have significant conjunctival fibrosis, depending on the extent of conjunctival fibrosis. In many patients, just using 1 or 2 medications, especially if they are not uncomfortable, don't have allergies to medication, a patient who is very old finds it difficult to come back after if you do another surgery, just let your ego go and start them on 1 or 2 medications. If they can survive their life with that, you are doing a favor to the patient by not massaging or needling the bleb and massaging and needling your ego. A repeat trabeculectomy is a very good option. Most of the repeat trabeculectomies are successful. But it will work only if you take care of certain things. If the first trabeculectomy has instantly failed, it is very likely that the second trabeculectomy that you do is also likely to fail very fast. There may be known or unknown factors in the eye which doesn't allow a bleb to not fibrose, or pro-fibrotic factors which you sometimes can see very easily. Sometimes it is just intense infiltration of the conjunctiva with lymphocytes, which happens with even one of the most surface-friendly drugs, beta blockers. So if you look at prostaglandin analogs, brimonidine, they are all much more surface unfriendly. And even with beta blockers, there is intense lymphocyte infiltration that happens in the eye. So there is a risk for fibrosis, using multiple medications over multiple years, risk for fibrosis, even if you don't see anything. Apart from that, you can have multiple factors that you can see. Congestion, conjunctiva that is very kind of fragile and paper-like. And then you need to have space. If there is an SICS incision on the eye, you cannot do a trap. If the first in conjunctival opening was very wide and there is a very wide flap, you cannot do a trap. Okay? That is why many surgeons prefer to do a superotemporal or superonasal trap. But if I don't see a risk factor, the best chance that you can give to a patient is to do a superior trap. So if you do superior traps for 100 patients, probably one is going to need a repeat trap. And that also, in our practice, we are able to manage by doing a superonasal or superotemporal trap in addition to the bang on superior trap. So it doesn't hinder your superonasal or superotemporal trap. Okay, this is a patient where if you see there are two PIs. One PI is on this side and one PI on this side. And you see there are two blebs. So this is a bleb which is failed, more vascular, lower. And this is a trap that is succeeded. It is a relatively less vascular bleb and it is quite raised. This is again another patient superior trap followed by a superonasal trap. The intraocular pressure is very, very much under control. Implants are indicated instead of a repeat trap if you have a poor anterior conjunctiva. The implants can be of various types and you very clearly saw what types of implants are available. RD or Ahmed clear path are non-valved implants, and when you have high risk of complications due to hypotony or risk for prolonged hypotony, these are two different things. So there are certain patients like who have a penetrating keratoplasty, who have uveitis, who have a retinal detachment surgery done earlier, they have high risk of complications if you create a prolonged hypotony. Then there are patients who have less chance of recovery from hypotony, like high myopia, large globe, patients with uveitis. In these situations, you should avoid a non-valved implant and proceed to AGV. This is a very interesting concept and I don't think it is understood very well. If you look at these images, can any one of you try to describe what you are seeing? The labels are there. An RD implant has been performed, right? And you see what you see there. Will anyone take a chance to explain it? Okay, I will explain it then. So you see here that this patient, 3 weeks after the implant, the ridge has not opened. Okay? And at the same time, a needling for a failed trap was performed and you see a bleb anteriorly. Pressure is 10 millimeters. At 3 months, the ridge is not visible. It means that the aqueous is now draining behind the RD implant and the bleb anteriorly has completely fibrosed because it has moved to the area of least resistance, which is above the RD. This patient did not have a hypertensive phase. This patient did not have a hypotonic phase and did really well. So RD is my favorite implant for patients who need an implant after a first failed trabeculectomy. And this is what I do for them. MIGS is of course something that you can do in patients with a failed trabeculectomy, a patient with failed AGV, and all Schlemm's canal MIGS, suprachoroidal MIGS can be done. There is no contraindication for performing them if they meet the criteria that I just mentioned for GAT. And this paper from, again, Davinder Grover's group shows you what an excellent control can be achieved in patients after a failed glaucoma drainage device and failed trabeculectomy. So you still have a patent Schlemm's canal which is waiting for you to drain aqueous into the collector channels and aqueous veins, which you can utilize. So to summarize, if you have sufficient conjunctival space and there are no inherent risk factors for failure, then you can proceed with trabeculectomy with mitomycin. Mitomycin more intense than whatever you used previously. No, and you have moderate target IOP, 14, 15, 16, and patient can use one medication. You can go with Schlem's canal mix. You need a lower target of IOP, then you can use an implant, RD or ACP, until if there are no high risk factors, or an AGV, a valve implant, if you see risk factors of problems due to hypotonia. Thank you.
Yeah, if there are any questions to Dr. Siddharth regarding GAT or whatever is discussed on, you can ask. Or else we will invite Dr. Anil Mandal from L.V. Prasad Eye Institute. He will deliver his talk on the recent advances in pediatric glaucoma surgery. Over to you, sir.
Good afternoon, everybody. Let us observe the two video first, and then I'll take help of slide and present. हाँ भाई ठीक से एडजस्ट करो नहीं अदर हॉल में प्रेजेंट किया No, I have presented just now in the other hall. Just now I presented in the other hall. দুটোতেই ভিডিও আছে All right, no problem. I'll speak on my own. The technique which you are seeing here essentially describes a new surgical technique for the management of advanced primary congenital glaucoma. Here is a patient of 3 months old child whose intraocular pressure was 36 millimeter of mercury, and we did illuminated microcatheter assisted circumferential trabeculotomy, and with that we added the trabeculectomy technique. Now, when we talk about the changing concepts of the initial surgical management for primary congenital glaucoma, it starts with goniotomy, then trabeculotomy, then combined trabeculotomy, trabeculectomy. In the year 2010, an excellent surgical technique described is microcatheter assisted circumferential trabeculotomy. Why circumferential trabeculotomy or 360-degree trabeculotomy? Because the whole of the trabecular meshwork, which is dysgenetic, is actually ruptured and is connected to the anterior chamber. The technique you see here, under a partial thickness scleral flap, we dissected the Slem's canal and we are putting a drop of viscoelastic, and then an illuminated microcatheter will be pushed into the Slem's canal, as you can see here, and it will traverse all around the cornea, that is throughout the Slem's canal 360-degree, and it will be retrieved from the original incision site, which is done at 12 o'clock position. This is a surgically demanding technique, and you can see the illumination at the tip of the microcatheter will actually guide you and will tell you that yes, it is traversing the normal pathway. If there is any misdirection, automatically you'll have to stop the surgery. You may have to cut open and retrieve the tip of the microcatheter and can do partial trabeculotomy, not 360-degree. Here is a situation. You can see it has traversed almost 270-degree and it is still going, and gradually it is insinuated and pushed. The microcatheter is pushed so that the tip is traversing and it is about to reach the original incision site at 12 o'clock position. Prolene suture trabeculotomy has been described. The advantage of illuminated microcatheter is it's a guide for the surgeon that yes, it is going through the 360-degree in the original pathway. You can see the retrieval of the tip of the microcatheter, pulled it, and then with the purse string suture-like traction, you can see entire 360-degree of the trabecular meshwork is disrupted and 360-degree trabeculotomy is completed. Now, after that, we used to do trabeculectomy part of the surgery. The marked area, 3 by 2 millimeter or 2 by 2 millimeter deeper trabecular tissue is marked, removed, and then an iridectomy is done. It is invariable that there will be mild to moderate degree of bleeding in the anterior chamber angle, and here with the Simcoe's cannula, with the irrigation and aspiration system, I have removed the clot, and then the trabeculectomy part is closed. Superficial scleral flap is closed by applying one suture at the apex. I do not put any suture on the sides. Conjunctival closure is done with a round-bodied needle with attached aetovehicle suture. This is the end of the surgical technique, and then we used to inject about 0.3 ml of dexamethasone in the inferior conjunctival, subconjunctival space. Successive photograph will show how is the condition of the eye. It is the left eye. Bilateral simultaneous surgery was done in the same session, and you can see how good is the appearance of the cornea seen at the 2 months and 4 months post-operative. Corneal edema cleared, you can see the Habs dry, and you can see the fundal glow through fundus red 2 illumination. The reason for doing or adding trabeculectomy to 360-degree trabeculotomy is in the advanced stage of developmental abnormality or embryological defect. In addition to isolated trabecular dysgenesis, there may be dysgenesis or fibrosis or maldevelopment of the post-Schlemm's canal pathway, that is distal outflow pathway, the collector channels, the aqueous veins, and ultimately the aqueous has to drain into the episcleral venous plexus. If that post-canalicular part of the pathway is defective, even if you do circumferential trabeculotomy, it is bound to give suboptimal result. And that's the reason in the advanced stage of the disease, we decided to really perform trabeculectomy in addition to circumferential trabeculotomy. The technique we described and published in the literature, Seminar in Ophthalmology, I call this as a Mandal technique, microcatheter assisted novel, distinctly advanced luminous technique. And to be very frank, the international authority, when they came across, and in 2010, when the technique of 360-degree trabeculotomy was described, the people are so happy that we have reached the summit, we have reached the highest stage of surgical competency. But my question is, in the advanced stage of the disease, when there is post-canalicular abnormality, post-canalicular outflow channel or the distal outflow pathway is defective, even if you do combined trabeculotomy only, metal trabeculotome, with the metal trabeculotome, or with 360-degree trabeculotomy, with the help of illuminated microcatheter or Prolene suture, whatever you do, the advanced stage of the disease may not be treated with the best possible way. And that's the concept, that is the thing I conceptualized and published in the literature for the first time. The name of the surgery, IMPACT, illuminated microcatheter assisted circumferential trabeculotomy and trabeculectomy. That's the concept. Devasis will present the next video. Now, what is a surgically demanding technique? I am doing this technique for last 1 year only. We have filed a patent for this illuminated microcatheter, which was devised with LBPI and collaboration with Arvind Eye Care System. This is working now. Watch the video carefully. While performing circumferential trabeculotomy, breaking of microcatheter is a serious complication. This video highlights the surgical technique of retrieval of torn microcatheter segment on a 4-month-old child with advanced primary congenital glaucoma. What follows now is the surgical technique for exploration of the Schlemm's canal under a partial thickness triangular superficial scleral flap. Harm's trabeculotome is introduced on each side of the radial incision to check the accuracy of the dissection. An illuminated microcatheter was introduced into the Schlemm's canal and then pushed gradually to complete 360-degree trabeculotomy. After traversing 270-degree, the microcatheter broke and the torn microcatheter segment was occupying 270-degree circumference of the Schlemm's canal. What follows now is the surgical technique demonstrating the retrieval of the retained microcatheter. By a separate incision at the lower temporal quadrant, Under a partial thickness scleral flap, Slem's canal was explored and the microcatheter was grasped and removed. Closure of the superficial scleral flap was performed by applying 3 10-0 nylon sutures, one at the apex and one on each side of the triangular scleral flap. What follows now is the surgical technique of primary trabeculotomy on each side of the radial incision done at 12 o'clock position. At the end of trabeculotomy, a 3 by 2 millimeter trabecular tissue is removed to complete the surgical technique of trabeculectomy, and an iridectomy was then performed. The triangular scleral flap is closed by applying 1 10-0 nylon suture at the apex of the triangular scleral flap. Conjunctival closure was done in a continuous fashion with 8-0 polygalactane suture and with the help of a round-bodied needle. At the conclusion of primary combined trabeculotomy and trabeculectomy, subconjunctival steroid injection is given in the lower quadrant. Note the location of the area in the lower temporal quadrant from which microcatheter segment was retrieved. Note the 1 year postoperative appearance of the bleb at 12 o'clock position. The child completed 1 year of follow-up with normal intraocular pressure with moderately elevated bleb and microcystic changes. The postoperative course was uneventful and the infant has age-appropriate normal visual acuity. I encountered, and I felt that I must share with you, because when microcatheter is broken and it is lost in the Slem's canal, it must be removed, and I felt this is the best way to do the surgery. Thank you. I think we should have some question answer.
Okay. So, if there are any questions to Dr. Siddharth or Dr. Mandal or to me?
Very good. No problem.
Okay. Thank you very much. Thank you, everybody.
Thank you. Thank you.